Good evening, everyone present here. I am Faraz from IGCP Group. Welcome all the participants on today's webinar. And I would like to welcome all of you. Like today is a very important topic for the panel discussion. And before starting this webinar, let me introduce the topic for today's among all the audience. The topic for today's live session is Guillain-Barré syndrome, that is a race against time understanding the early warning signs. That is a very important topic. We have the experts, we have the moderator, and two of our expert panelists who will discuss in details about the topic. So, being further delay, I would like to invite the moderator for this session. He is none other than Dr. Vijay Varat, sir. And let me share some of the achievement of sir. Sir is consultant allergist, pediatric pulmonologist, and clinical immunologist. And he is consultant at Sai Eye Asthma Eye Hospital, Shaidri Hospital, Imamdar Multi Specialty Hospital, Pune. Sir, I would like to welcome and welcome to the show once again. Sir. Great honor to have.
Thank you. Thank you, Faraz, for the introduction. Thank you, IGCP, for always initiating the latest topics. Thank you, all the viewers. Thank you.
Now, sir, I will
So,
request to introduce the panelist for today's session, sir.
yeah.
It's
So,
over to you.
today, as Faraz said, this is a very important current scenario. And I would like to invite today's panelist, Dr. C.S. Narayanan, who is a very well known figure in India. I mean, he doesn't require any introduction in the details. And he's currently the chairman of Manipal Institute of Neurosciences, Delhi. So, welcome, sir, please. I'm so fortunate to have you on the panelist. Then
Thank you so
another
much.
is Madam Dr. Gurusaram Sidhu, HOD of Internal Medicine of Sidhu Hospital, Ludhiana. And Madam is busy with some emergency, so she will be joining after 10 to 15 minutes. And till that time, we will start her. Even just last month only, I had a discussion with Madam on the pneumonia and what should be the approaches. So now currently, I think most of us know about GB syndrome, how suddenly there is a spurt of it, and a lot of cases have come up because of, and there are many theories behind that. So we'll have the experts' opinion today, like how we can manage this practically, as well as what are the scenarios, why this is a sudden spurt into that. So practically, as a clinical immunologist, last my 34 years experience in this field, and we used to see GB syndrome. It's not a new disease basically. I mean, we have seen these cases previously also many times, but sometimes, like at least within 6 months, one patient, or within a year, three or four patients sometimes. But it is not that way. Within few weeks, we are having, like in Pune's today's situation, around 29 cases have been already admitted. Something in the afternoon, one of the webinar in Pune was happening from the corporation, and I was attending that. So why there is a spurt? So we'll see that. So for that, Narayan sir, I will ask to like have a question, like what are the most common clinical presentations of GBS and how they have evolved over time? Please, sir.
So, actually, GBS is a broad rubric for a variety of clinical presentations. The most common presentation is what we call AIDP, or acute inflammatory demyelinating polyradiculoneuropathy. It's a long name, abbreviated as AIDP. In this presentation, the commonest is what we call ascending paralysis, wherein the patient may have slight weakness in the lower limbs, and which gradually creep upward to the body, initially involving the lower limbs, then the trunk, then subsequently it starts involving the cranial nerves. Very commonly, 50% of patients may have facial paralysis also, and they may have bulbar symptoms. In addition to that, two less well recognized symptoms are the autonomic symptoms and the sensory symptoms. On presentation, the patient may have minor sensory symptoms which could be ignored by the patient, and that is why many early cases may be missed. So basically, it is an ascending paralysis with minor sensory symptoms associated with cranial symptoms and autonomic symptoms. But the most disastrous involvement is that of the respiratory muscles, wherein if they're involved, about 10 to 30% of patients may actually go to ventilator dependence. This is the most common presentation, and there are other presentations as well. There could be this AMSAN presentation, which is acute motor sensory axonal neuropathy, or there could be pure sensory involvement also, that is ASAN. And these are the presentations which are more common in the current outbreak, which is due to the presentation after Campylobacter jejuni involvement. There are other variants also, depending on the molecular mechanism involved. There is one syndrome called the anti-GQ1B syndrome. And in this syndrome, again, there are three subtypes. One is called the Bickerstaff encephalitis. One is the pharyngocervical brachial involvement. And the third presentation called, or possibly the most common presentation of this syndrome is the Miller-Fisher variant, wherein there is ophthalmoplegia, ataxia, and areflexia. And there also could be very restricted forms. In fact, some patients could have isolated mydriasis alone, but these are extremely rare. And we should concentrate on the most common presentation, that is AIDP, where there is ascending paralysis and with gradual involvement of the lower limbs, the trunk, the cranial nerves, the autonomic nervous system.
Thank you, sir. And specifically, this 2025 in Pune specifically, we found that like elders and the children are more suffering. So, what could be the reason for that? Yes, sir.
As I said, it is a very heterogeneous disorder, and
Yes.
normally there is an antecedent infection in the body, which could be either a respiratory infection or a GI infection. Respiratory infection, being the antecedent cause, is much more common, about 70%, and 30% follow a diarrheal infection. In the Pune outbreak, it was Campylobacter jejuni. And this is the immunological trigger for the onset of GBS. Subsequently, there's immune damage as well. So there's a lot of heterogeneity in both the patient population and their susceptibility. So it is not a uniform disorder. So depending on the host responses, firstly, there is this what type of pathogen it is. That itself can, as the bacteria keeps dividing, it keeps undergoing a lot of genetic modification. Subsequently, there could be differences in the susceptibility of the individual. For example, the elderly and the children could be more susceptible to getting that immune response and what we call the molecular mimicry, which is the most commonly thought of pathogenetic mechanism for GBS in this subgroup of patients. So possibly in this Pune outbreak, there was this host factor which is more responsible in their affecting the elderly population and the pediatric population.
Absolutely, sir. Absolutely, you're right. And as a clinical immunologist, we always say that this dysregulation of the immune system, it may be a like lower immunity or hyperimmunity, and then the body reacting in a autoimmune way and damaging the different parts of the body, and specifically this disease as the nerves get damaged. So there are multiple factors, and maybe because of the global warmings, pollutants, then lifestyle, then as you said, heterogeneity, like any comorbid conditions underlying any chronic diseases, and then it altering the immune response. And that's why each and every patient is different. But this scenario specifically, we have seen the children's and elderly people suffering over there.
If I
But
may
even
add one thing, that is why, though Campylobacter jejuni infection is very common, it does not affect the whole population. Only a minority of patients go on to get GBS. So the diarrheal infection itself is very common. So there are complex mechanisms by which some patients only get the GBS, and the vast majority don't get GBS.
yes. So the people should be, I mean, as you rightly said, the people should take precautions, but they should not be unnecessarily scared also. And precautions in the way, as you mentioned, these symptoms and signs, if somebody is developing. In Indian scenario, the practically what happens, ki, the people's tolerance is very high. So if somebody has a viral infection, they will just go on taking self medications, then whatever ORS and salt water at home. And suppose weakness is happening, they will feel ki, okay, this is maybe because of the diarrhea. So they should not be into that misconception, And suppose something is different, they should approach to the practitioner, and they should get investigated, and the experts advice should be taken, so that it is uncommon, but still, whatever the case is, for that family it will be very debilitating. And we'll see further how the management and all, but then it becomes very uh, complicated. So the people should be definitely aware about that, and they should take some simple precautions also, and they should not take it casually also. I mean, they should not be scared, but they should be, suppose some different symptoms are there, and so as usual, they should not take it, it is because of some viral fever and all, nothing to be worried, we'll see later on. So because, like, what do you say about this? Like, suppose the patient neglect it, and if it progresses, then what are the complications like?
So, firstly, like you very correctly said, it should not be classified as an infectious disorder. So, we have so many like typhoid, cholera, and so many things that are purely infectious disorders. This is a post-infectious complication. So, a person gets an infection, and this post that infection, there is a autoimmune response which damages the nerves and causes this Guillain-Barré syndrome. So, and it's a very small minority. In fact, previously, before this Pune outbreak, it used to be like 1 in 100,000 patients would go on to get this complication. But obviously, there is a clustering of patients in Pune which has caused the alarm. So it is definitely not an infectious problem. So one should be less alarmed that every patient who gets this diarrheal illness will go on to develop this outbreak. It's a very rare condition that way. And except for in this Pune outbreak, there was a lot of alarm because so many cases happened together. I think the latest count is close to 170 in this. But there was one previous cluster in Peru where almost 3,000 patients happened, and that was also attributed to this Campylobacter jejuni. That happened in 2019. That is possibly much larger outbreak than this Pune outbreak. So the important thing is the early signs of this disorder can be missed. So when a person just has some kind of tingling numbness in the lower limbs or something like that, and they're still walking about, carry on doing their duties and all that, so the thing may be missed. It is only at a stage when they start having some walking difficulty. Like I said, it starts in the lower limbs, so they may have little bit of gait unsteadiness. They may ignore that also. And subsequently, when they start requiring support to walk, that is when possibly they will report to the physician. And even then, many physicians may attribute it, since it is a rare condition, and if they're not particularly aware of this condition, when it happens in Pune now, I'm sure most of the physicians and neurologists will be looking for it. So the chance of it getting missed are very low. But if it happens in the larger public and some other place where the awareness is less, the early signs and symptoms will be missed. And it is important to notice these signs and symptoms because the earlier that we start treatment, the better the response. The usual course of the illness that after the onset, it continues to progress for about 2 weeks. And by definition, it can progress up to 30 days. If it progresses beyond 30 days, it is actually not no longer classified as AIDP, but it is classified as subacute inflammatory neuropathy. And if it progresses beyond 8 weeks, it is classified as something akin to this condition, but totally different, both in terms of presentation and the management. That is called chronic inflammatory demyelinating polyneuropathy. So we must catch these patients early and start treating them in the first 15 days when the disease is still progressive. The outcomes are so much better if they're caught in this stage and the treatment started.
Thank you, sir. And like clinically, how do you differentiate like GBS from other neurological disorders? Can you enlighten on that? Yes, sir.
That's a very important point. Like I said, there should be a high index of suspicion in patients presenting with this classic presentation of minor sensory symptoms, followed by ascending paralysis, followed by cranial nerve involvement, most common being facial diplegia. And they can also bulbar involvement in the form of difficulty in swallowing. They can have autonomic symptoms and they can have respiratory involvement. But there could be some other mimics. For example, a spinal cord involvement can also present with lower weakness to begin with. They can also have gait unsteadiness. But these patients, if we carefully clinically examine them, they could be have a sensory level. So that is a very typical thing. They don't have sensory symptoms, but on examination, there are sensory level in the trunk. That is a clear giveaway that it is not a GBS, but a spinal cord involvement. In addition, unlike the areflexia, the absence of reflexes in GBS, patients with spinal cord involvement will have hyperreflexia, extensor plantars, and early involvement of the bladder. One important thing to remember is that in GBS also, in the very early stages, the reflexes may still be preserved. And in some variants of GBS, like AMSAN, or this pharyngocervical variant of Bickerstaff encephalitis, they could have extensive brisk reflexes, but that is a rarity. The vast majority of cases, there is absent reflexes in GBS. Other conditions which could resemble GBS are like a brainstem stroke. But in a brainstem stroke, they usually have asymmetry, and they have very gross abnormalities on the MRI, which is absolutely uncommon in patients with GBS. Patients with myasthenia gravis again have muscle weakness with very little sensory symptoms, but they have a fluctuating course, and on examination, they could have very clear-cut presence of anti-choline esterase receptor antibodies. Patients could have some conditions like tick paralysis, which is very uncommon, or botulism, again, not very common in clinical practice, but they can be mimics of this condition. In botulism, there is descending paralysis, and one very clear-cut sign in botulism is a fixed pupil. In tick paralysis, again, it is a very close mimic of botulism, but once you remove the tick, the patient becomes all right. There are various other types of neuropathies like paraneoplastic neuropathies and autoimmune neuropathies, which have a pure motor presentation. Like in GBS, these can also be confused with GBS, but with appropriate investigations, I think we would be able to diagnose the condition correctly in the vast majority of patients if we take recourse to some very common investigation, which I'm sure we'll be talking about subsequently.
Thank you, sir, and welcome, Dr. Sidhu, ma'am. I
Thank
think,
you, Dr. Vijay. I'm sorry. Thank you, Dr. Narayanan. I'm really sorry for joining little late. It was just being busy, and
yes,
yeah.
yes. Ma'am. So, ma'am, we are discussing about the GB syndrome, whatever the now epidemic is happening in
It
Pune
was
specifically,
I was
and
kind of really interested to know what is happening in Pune with so much of news coming down. And then I was asking my colleagues here, what is the incidence here? Then they were saying we're not seeing even myself. I have not seen a single patient 1 or 2 months, and this is right now. I mean, not the current problem in our state. It is as usual what we normally see. The incidence was as usual what we normally used to see as an LGBS.
okay. So already Narayan sir has said about the why there should be the things and heterogeneity of the disease, as well as how clinically we should differentiate between GBS and the other neurological disorders. Basically, now coming to the after the clinical examination and signs, what should be the diagnostic approach? Sidhu ma'am, if suppose a GB syndrome patient comes to you, how do you go? I mean, uh, as a diagnostic
Right.
purpose,
Yes.
investigations to
First
be
of all,
done.
like we said, we can't be wasting time. A clinical diagnosis is very, very important. And absent reflexes, they really help us, absent reflexes, ascending type of a paralysis, and sometimes it is so rapid, and sometimes it mimics, like the patient only complains with difficulty in breathing, and sometimes it comes so much so that the patient rapidly goes into respiratory distress. But absent signs, they are very important. And in our old times, we used to rely more on the CSF with the protein cellular dissociation. But now EMG and nerve conduction studies, they are so much helpful that they are the ones which are easiest to do at that time, and they are the ones which will clinch the diagnosis, other than our clinical examination which we have done and the way the patient is progressing.
Thank you. Narayan sir, would you like to add anything? like how the EMG
Yes,
nerve conduction,
one
knee,
important thing, yes, like we discussed the clinical heterogeneity of this condition, and the vast majority of patients have demyelination of the nerves. That means I'm just explaining it for the sake of the audiences who are not familiar with neurology. The myelin is the covering of the nerves, and the vast majority of the patients are demyelinating disorders. In some variants, particularly the variants like MAN and MSAN, which follow the campylojejunal infection, they predominantly involve the axons, that is the nerves themselves. So we have to take recourse to some of the tests, like ma'am said about the nerve conduction. The nerve conduction can very clearly differentiate between the demyelinating form and the axonal form. In the demyelinating form, the earliest sign that we get within a few days of the onset of GBS is the absence of F waves, or there is temporal dispersion of the F waves. And then subsequently, there is delayed distal latency, there is reduced conduction velocity, and there is conduction block. And this conduction block is a very important finding in patients in whom we do the nerve conduction in patients who got demyelination, whereas it is not present in those with the AMSAN and the SAN variations, which are which commonly follow this Campylobacter jejuni infection. As far as CSF goes, it is this albumino-psychological dissociation that ma'am was talking about is very important, but it is usually delayed. It is usually seen at the end of the first week or after 10 days or so. So it may not have a role in the immediate diagnosis, but once we suspect and start treating the patient, it kind of further adds value to our diagnosis.
Okay, sir. Thank you. And now, after the investigations and clinically also, once we diagnose it, so what are the current treatment options in GBS? Yes, Sidhu ma'am, would you like to enlighten?
Yes, definitely. The best treatment is IVIG, which we've been using, and the proper dose of IVIG. What we normally tell our patients is actually the cumulative cost, because if you tell them one vial cost, they really are not that much mentally prepared for that cost. So, proper calibration of the IVIG dosages, and then giving that IVIG over a period of 5 days. And if the center has a facility of the plasmapheresis, that is another good choice. Uh, well, I would say steroids if the patient cannot afford anything. Neither he can go for IVIG nor he can go for plasmapheresis, and cost is the issue. Well, then that's something what we can help, we got to do something. So, in those cases only, otherwise, not the treatment of choice. The treatment of choice remains IVIG, and the response is very, very good with IVIG. And as we've been listening, that the number of cases in Pune were like 166, and only mortalities were around 5. So the course is a very prolonged one. The recovery is not going to be immediate even after IVIG or after plasmapheresis. It is going to be very slow, and many of the patients, if they haven't shown any improvement within next 2 weeks, and a second dose of IVIG also is helpful sometimes. And then, of course, the maintenance over a period of time, which is very, very tough to maintain the patient on ventilator with no neuromuscular power, with infections coming up. And then many times you need, there is a trauma, there is a clot in the bronchus, there's a clot in the right or a left bronchus, and then you have to do bronchoscopy. So that is very challenging. The physiotherapy, the nursing care of these patients is, especially if the patient happens to be obese, and when to do tracheostomy, when at what time, if you think the patient is not improving, you would need to track the patient, and then to maintain the patient on a tracheostomy. But in my experience, we have had a patient who was on ventilator for 5 months. They were fed off of not fed off, I would say. One institute, it's normally for a patient, you shift from one to the another, and ultimately they kept the patient on ventilator at home also. But the patient recovered after 5 months. So to keep a patient alive for 5 months in that kind of a scenario is a very very big challenge. But patients do recover. That's the beauty of GBS, and that's one thing that if you are able that the patient passes time for 4 or 6 weeks, then if he's out of ventilator, then the rest, the things can be managed with the nasogastric feeding, with a good positioning, with a good nursing care, with preventing bed sores, and off and on antibiotics which the patient needs. So it's a long course where the patient takes very long for treatment, but still not discouraging. This is a disease where we can give a lot of hope to our patients, and we can continue with the good nursing care, prevention of infections, and if the infection has occurred, immediately taking care of that, good care of lungs, even if they need, if there's a clot, doing a removing a clot by bronchoscopy, and looking at the infections, prevention of pneumonia, so on and so forth, prevention of ischemia, prevention of sepsis, and markers we need to continue doing that, procalcitonin, CRP, proper antibiotics. So these are the things at what time to initiate antibiotics. So antibiotics are not going to help LGB. It is only going to help for the prevention of sepsis, which is the main event which is going to take the life of the patient. So, still hopeful, and I think patients can really be saved out of LGBS. And though the course is very prolonged and it's a long course, and the thing is, you what you lose that you gain in the last. If there is a foot drop, if the legs are involved first, and the respiration in the end, the respiration would come first, those muscles would improve first, but the muscles which are lost first, they will be the last one to come. They will recover at the last time. So whatever losses are initially, then the patient progresses, then patient starts improving, he starts improving from here only. These things will improve, but it started with, that will be in the end of it. That's why we most of the time patients end up with a foot drop, bilateral foot drop, and many of them have, if the throat and things were involved in the initial stages, bilateral facial nerve palsy. These things, these are the ones which recover in the last, or may not
Thanks for
recover
your
at the
experience,
end of
ma'am.
it.
Narayan, sir, will you like to add anything?
Yeah, actually, Madam Sidhu was talking about the more severe spectrum, but we must understand that there is a very wide variation in the severity of the illness also. Some patients very mild and they may not actually require any immunomodulatory therapy at all, and they may recover within a few days. But there's a definite a small minority of patients, not small minority, some patients who would fall into the severe spectrum, and like ma'am was talking about, require ICU management and things like that. So there is a wide spectrum. And there's some point that I'd like to add. Firstly, this plasma exchange and IVIG are both equally effective, but only if they started in the first 15 days when the illness is progressive. And studies have shown that they're equally effective. Secondly, there is no benefit in combining both modalities. Some of them will say, okay, why not give both if both are effective? That has not been found to be a valid strategy. Regarding corticosteroids, yes, intuitively, since they're being used for so many autoimmune disorders, including the chronic inflammatory demyelinating neuropathy, which is where it is one of the mainstays of therapies. In GBS, several studies have not shown that it is better. In fact, some studies have shown that it is worse. But like ma'am said, in resource limited settings like ours, when we don't have any option, so some of us may end up giving steroid, but scientifically speaking, it is a very controversial subject. And then regarding the acute ICU management, also there are some things that I would like to add. The ventilatory management is very important, and where we need to have ventilatory strategies on when to start the intubation, when to do electrocutostomy. And some other things, and most importantly, we must manage the autonomic instability part. So when the patient has tachycardia, when the patient has hypotension, they can have very labile blood pressures, which have to be managed. And in the long-term strategies, they have, like ma'am said, all the complications of a person is bedbound for a long time. One important complication that I'd like to prevent is deep vein thrombosis. So we must give prophylaxis for DVT in all these patients. And ma'am has very elegantly described all the problems which happen when persons are very sick and they require ventilation for a long time.
Thank you, sir. I mean, as we discussed, we have to be very vigilant, and the integrated approach is important with the whole team of people. And thankfully, I mean, most of the cases are seen in Pune rather than the rural areas. So that's very good. Otherwise, resource poor settings in poor areas like rural areas, it will have been a very difficult because even the civil hospitals and all, they don't have all these facilities and all the specialists to manage that. So whatever the cases are seen in Pune, and they have been to the best setups. So it is very easy, as we discussed, the nursing care since then to autonomic dysfunction, then ventilatory cares, and those patients which really require a good ICU setup and all. So again, long-term wise, post recovery, like the patient comes out of ventilation, everything, then again, that also plays a very important role, as Sir also said about autonomic involvements and all. So, so how should be the approach into that, Narayan sir? Like, so once the patient comes out of ICU, then what should the care should be taken in the uh, normal like setup or at
So
home?
the rehabilitation is what we are talking about, and
Yes.
it has to be a multidisciplinary approach. As neurologists, our job, in fact, is most important in the acute stages when we are giving those immunomodulatory medications or plasmapheresis in the first 15 days. Thereafter, we have to progressively involve other members of the team like physiotherapists, occupational therapists, and all that. And the important thing to remember is that physiotherapy should start when the patient is still in the ICU itself. The earlier you start the physiotherapy, the better it is. So we must use passive range of movement exercises to begin with. Then it could be assisted range of movements. All this should start in the ICU itself. Then subsequently, in the subacute phase, when they're shifted to the ward, then there can be like some muscle strengthening and balance training and all can be started when they're moved from the ICU to the ward. And long-term rehabilitation, when they go home, when they still have some motor deficits, would involve the honing of their fine motor skills and vocational therapy. And once we do all this, or some speech therapy, if their speech is involved, if we have an integrated approach in concert with rehab experts, then the outcomes are so much better. So all this must start in the ICU, carry on when they are in the ward, then post discharge, and gradually the patient can improve dramatically. In fact, patients were on long, like ma'am said, she's seen patients who've been there for 5 months. I had one patient when I was in Bay's Hospital in Delhi camp who was on ventilator for 5 years. So even that prolonged, and it all depends on how they are managed. But the good news is that many patients who are, even those who are on prolonged ventilation, recovery does happen. Particularly the demyelinating variants, the recovery is much more. In the axonal forms of GBS, recovery could be less, but ultimately the vast majority, 85%, would recover without any deficit. 15% may have some deficit, but almost all of them recover. Well, this is the good news. The bad news is that there is some amount of mortality, particularly in the acute cases. Like ma'am said, there have been about 5 deaths of the 170 cases that have happened this recent outbreak. So rehabilitation is a very important part of management of GBS. And one other thing is that while we are doing all this, we must always give hope to the patient. So, when they're very sick, they're very anxious. So, social rehabilitation is also important. We must keep on reassuring them that they are going to recover, they're going to recover well, they'll start walking. And in actual fact, also we see patients who are bedbound for a long time. If they are followed up for a year, 2 years, they come back walking and remain perfectly fine and able to do all activities of daily living.
Thank you, sir. I mean, as you rightly said, most of the time in our community, suppose the patient is on a ventilator, there only they lose the hope. And after that, again, the paralysis, suppose neurological, the most of the relatives and all, they will say, "Ki, like, now the patient has gone, nothing can be done now. Throughout the life, he has to be there." But as you and Sidhu madam said, like the reassurance and the good part is that most of the patients come out of this very well. They can have a very good life afterwards, also after a proper rehabilitation, neurologically as well as occupational therapy, physiotherapy, and all. And as Sidhu ma'am, you said, like in many of the patients, even if not taken properly, and then the bed sores or other secondary infections into the lungs and all, they can really cause a problems. So how should be the approach to that also, like, so not to have the bed sores, not to have the secondary infections
Yes.
into the lung. Yes.
That's the most important care, and that's the most challenging part, because whatsoever deaths will be happening in mortality, if we kind of are not very aggressive in that management, that is where we are going to lose the patient. And ICU care, proper ICU care means like keeping your bed position 15 degrees angle, dedicating one or two nurses only to that patient, day separate, separate nurses, so that there is no cross infection from one to the other patient, proper suctioning from the patient. It doesn't pressure of the of the your suctioning system, which is also very important. Sometimes what happens, even if the patient has got a tracheostomy or the patient is on an endotracheal tube, the suction pressure is higher, which sucks on all the mucosa, and slowly over a period of 3 weeks to 4 weeks, it's kinds of a create a tracheal stenosis. So every small little detail, that the oral suctioning has to be from a different catheter, the tube suctioning has to be from a different catheter, and catheter needs to be changed. You do your hand washing before taking on to the patient, or before suctioning, hand washing after suctioning of the patient, oral suctioning different. Keep on sending the samples which you have the catheter tip cultures, so that you know if there is any bug, if you need to change the antibiotics. Many often you will not be able to grow the bug because the patient's most often on the antibiotics, but still, still if you can catch it up, it is still much more better. So that thing, because you don't have to be too aggressive so that there is not much of a bleeding, because if there is bleeding, then also there would be clots somewhere or the other, and they would keep on blocking the either the ET tube, or they will be on the right or the left bronchus, which can cause sudden collapse of the lung, and then the collapse of the lung followed by fall in oxygen saturation. So these are the measures. And then many times we have seen, patients, we need to bronchoscope them and remove and do the proper suctionings and all. And then proper, of course, the prevention of pneumonia is the biggest difficult, most difficult task in these patients. And then feeding of these patients with the proper nutrition, maybe with Ryle's tube, and proper hydration. These are the two three mains, because you got to keep the lungs not very wet, relatively drier also, but you keep still have to maintain a proper hydration of the patient. And you never know, all these patients, if it's a male, if it's a later age group, they could have been suffering from the cardiac diseases as well, where your fluid, I mean, you delicately have to very maintain the fluid and electrolyte situation of the patients, keep the lungs dry, at the same time keep the kidneys enough hydrated so that they keep on producing enough urine. The patient is on so many lines, probably you've needed a central line as well, and then you got a tracheostomy or endotracheal intubation, you have the peripheral lines, you have the catheter in position. So all these cultures, repeated cultures from these points, and sores at all, pressure sores need to be avoided at all cost with air mattresses and proper turning of the side of the patients. So all these and proper antibiotics. You got to be careful. Patient is catheterized. Maybe if the patient is a diabetic, he's probably going to have some amount of renal insufficiency or renal damage. You got to check your drugs, proper suitable antibiotics, which is again according to the antibiogram of your ICU, which is again very, very important. What infections the patient can have. These patients, from the hands of the caregiver, they can get staph infection, streptococcal, Klebsiella, and if in the ICU, whatever is grown in the ICU, or proteus from the urinary, from the catheter, or E. coli. So antibiotics, selective antibiotics, where you got to save some antibiotic because it's a prolonged course. You just can't keep bombarding with all the antibiotics and then you have nothing in your hands. So you got to start whatever is feasible, whatever is less toxic. Like for example, if we need for chest, if you can give nebulization of colistin in a smaller dose, better save it for nebulization only rather than giving intravenously, and prevention for renal toxicity. So a very dedicated team approach is required in such sick patients. And physiotherapy is the role of physiotherapy, chest physiotherapy, the peripheral physiotherapy, prevention of DVT. So these are all very, very important factors which need to be done in these patients. And they are for a prolonged time. And again, these patients are actually, the brain is okay and they are suffering and they know that they are suffering. That's the biggest tragedy. They are not unconscious, and you don't want to properly sedate them also all the time. You don't want to make them unconscious. Many times you want them that they should be on the SIMV mode of ventilator. Patient should understand it, and he should be conscious, and he should be still cooperative with his eyes if he can, even move his eyes, and so that the patient should be cooperative. And still, it's a very, very dicey how much sedation you want to give to the patient and how much you want to keep the patient awake, how cooperative is the patient, how much he understands. His vestibulocochlear nerves is absolutely normal. He can listen to us and whatever we are saying, and but he cannot show us the emotional trauma he's going through. So these are lots and lots of things. He knows he's not unconscious, but he has got a tube in place, and he knows what is happening to him, and he knows he can't even lift his arm, he can't even lift his legs, he can't even tell how hungry he is. So you got to kind of within eyes to eyes, you can make the patient little understand. Are you okay? You can blink your eyes. You can tell me this, and that kind of a relationship with the caregiver, with the doctor consultant is very, very important when it's kind of a very prolonged therapy for the patient.
Thank you, ma'am. As you rightly said, like the medical part and the management, we all do, but the psychological, not only the relatives, even to the patient himself, because he can understand everything. So the positive atmosphere in that room is very important to
Yes,
ensure him. So that is a very important part in medical science. We all know, like if the patient's
yes,
positivity is good, he can recover very fast rather than negative
absolutely.
approach. So definitely, it always helps. And as we discuss about all these different approaches in depending on the severity of the disease, the most important part is again monetary part. Like
Yes.
so much money is spent in
Most
this
difficult
thing.
part.
Yeah, most difficult part. And there again, like how the insurance is it covered under insurance? I mean, most of the things acute.
It
I
would be
think
covered.
definitely. Yeah.
It would be covered because it's not an alcoholic, it's not a suicide, it's nothing to do with that. It would
Yeah.
be covered.
And again, the
But
post
I think the
also.
government has to step in, like in the Pune outbreak, the government has stepped in because if they go to a purely private facility, I think insurance also got some capping and things like that. So
Yes.
they will run out of the money very quickly if they
Hmm.
require this prolonged care for months on end, rehabilitation months on end. But fortunately, the government in our country has taken steps to ensure that there is a capping on the expenses borne by the patient themselves. And they've, in fact, given a lot of guidelines to both the government and private hospitals in and around Pune that all these patients should be treated in special wards, and have made sure that the financial burden at least is not very big on them.
That's a very
Sir,
good
I
thing.
would want to know in Pune cases, how sick these were the patients, and what was like they were very sick, most of them, or they were like mild, moderate, and severe.
Out of 170 patients, from what I've seen in the literature so far, 55 have already been discharged. About 20 required ventilators, 20 to 30% patients required ventilators, and 5 persons died, including one chartered accountant who made big news. So, and since there's all these patients had this GBS following this Campylobacter jejuni, which usually is the most severe form, and which is the axonal variant. So this would be the more severe spectrum of the thing, and other types of purely demyelinating types of ARDP and all, the prognosis will be even better.
Yes, the worst prognosis is with axonal neuropathy. So I don't know about your experience. I've had a patient who's got a very bad axonal neuropathy. He was bedridden. Then he was discharged. He was little better. This LGB was not the reason. This was we didn't know what was the reason. He had just stopped walking and he was just brought in bed. But the since the nerve conduction studies and they said muscles were lost, he probably had no chance of recovery because it's an axonal neuropathy. So we did. I just gave him, of course, we told him it's not going to improve. Gave him a very small dose of steroids, and he's been coming to me now last for 6 to 8 months. He's improving gradually, and he's improved dramatically.
I know. See, anecdotal reports, like I said, many of us do out of the box and or treatments which are not in the guidelines. So all of
Yeah.
us have enough experience, and when we are the back is against the wall, we do treatments which are not part of the guidelines.
Yes.
Out of the guideline, treatment is definitely part of our practice, and I'm happy that your patient improved. But as far as science goes, corticosteroids are not to be given in GBS. If
Yes. It was not
other
DBS.
facility, if the facilities for IVIG and plasmapheresis are available, you must not resort to the use of corticosteroids.
No, this was not a case of GBS. We didn't know why was he had
Yeah,
gone
so
into that.
like I said, there are so many other
Yeah.
autoimmune neuropathies
Other
where
causes. Yeah.
steroids are the mainstay of treatment, including
Yes.
CIDP. So it is not that they don't use, and instinctively all of us would think it's a steroids improve such a vast majority of
Yes.
autoimmune disorders. It should improve.
Automatic.
It should be beneficial in GBS, but studies have shown that they are not useful.
Thank you, sir. Thank you, ma'am, for really having a very good discussion and enlightening everyone on your practical experiences as well as whatever the current epidemic going on. Siraj, any questions are there? Hello,
Yes, sir.
Faraz. Sorry, Faraz. Any questions are there?
Yes, sir. It's already shared, sir. Like till now, I can see no questions, sir, from the
Acha,
audience.
okay. I mean, whatever the questions which have been already answered. Okay,
Yes,
thanks. So
already
that's
we
a
have
really
taken prior.
okay.
Yes, sir.
Very nice. So, Narayan sir, will you like to give any message? I mean, in this and the summary
Yeah,
of the today's discussion.
yes. One important thing is to understand that these clusters, like the one which are happening in Pune, are very uncommon, and we must not get panicky. And it is not an infectious disorder; it is a post-infectious complication. Whereas diarrhea associated with Campylobacter is very common, the occurrence of GBS is not so common. So one should not panic. And in a situation like this, when we start early treatment, the vast majority of patients will improve without any disability. The minority of patients who are in the serious end of the spectrum who go on to require ventilation and all that, also with proper care in the ICU setting and subsequently in the wards and at home, even those patients, the vast majority of them will improve and they'll walk back into your OPD. So we were said all stages of the illness give both hope both to the patient and to the family.
Thank you, sir. And even practically, we have also seen, like in Pune, even the private and the corporation and the government, the coordination is so good. Daily, we have to report now that before the GP syndrome, again, like the whatever the in China the HMPV was happening. So since then only the corporation was daily sending us the Google Sheets to fill up like any cases of pneumonias or any SARI cases we were reporting. Now we are reporting any acute paralysis or any cases. So that's a very good coordination between everyone so that the community will have a benefit to that. Sidhu ma'am, will you like to say any message? Yes, please.
uh, it is just another, like what we observed. It's post viral. Everything is post viral basically, and we what I two cases which I saw recently were, they were not of peripheral neuropathy, episode of fever, and then the person is having acute cerebral episode like cerebritis kind of. MRI didn't yield anything. But not only, what I mean to say, post infectious, it is not only peripherals that radicals and nerves will be involved, it's even the cerebellum, even in the brain. These things can happen. So once it is in the peripheral, we call it Guillain-Barré, but it is, we have seen it in the post infectious autoimmune things happening, demyelination happening, even in the central nervous system, the brain and the cerebellum, the things are, though this may not be associated, but it's post-infectious. Whatever infection it is, bacterial now we find out, but mostly all this time we've been blaming for the viruses, the Zika or influenza or any other viruses which were happening. It's only this time that Pune, well, it's been there also in the, it's not something new, Campylobacter, but the kind of a epidemic has happened with Campylobacter, which Pune has reported now. So,
So as we
sir, what
yes,
was
ma'am.
the main, this Campylobacter, was it like the cultures were sensitive to which drug for the Campylobacter?
Sir, will you say about that?
Dr.
Yes.
Narayanan?
Yeah, they found this Campylobacter positive in almost about 30%. They've cultured it, and Campylobacter diarrhea is a very common thing. It would respond to any of
Mm,
the
any of
drugs. So
these.
Even
we actually
ciprofloxacin.
need not, yeah, we need not concentrate on the treatment of Campylobacter.
I
This is
understand
the
that.
thing is that, and so it's not going to reduce the incidence of GBS if we treat the Campylobacter and they're not going to get
Yes,
GBS. It's not like that. Number one.
post-infectious basis.
Number two, an important point that I'd like to say is yes, the government has responded commendably well after the outbreak, but I think after so many years of independence, we must ensure safe water supply, potable water, because most of this outbreak particularly happened because of unfiltered water being like supplied to a few villages downstream from the Kadakavasla dam. That is the hypothesis that is being there. So I think to make filtered water, drinkable water, potable water available to everyone is very, very important, because this time it was a small outbreak, but suppose, let's say, the whole Pune Municipal Corporation has got a problem with drinking water, the outbreak could be much bigger, and it could be there in other parts of the country. So public health measures are very, very important. It is good to respond very well, which they have done. I think the Pune Municipal Corporation, the government of Maharashtra, the government of India, everyone has kind of pitched in and kind of done a lot of research and are trying to do their best to treat these patients. We must proactively make sure that our public health measures are in place so that similar outbreaks do not happen. And it may not be GBS, it could be something else. So we must make sure that our public health systems are in place.
Thank you, sir. Somebody has asked, is it contagious? So definitely it is
No, it
not
is
that way.
not. It
Yeah,
it
it is not that.
it is
Yes.
not. It is only a common source. Like it started. from a common source of contaminated water. So it is not spreading from person to person, but they all had contaminated water, which caused this diarrheal illness. And a minority of them went on to develop this post infectious immunological complication called GBS.
Yes, sir. And absolutely, like as we were discussing about the things, why these different autoimmune disorders and all, because the inflammatory disorders are increasing because of many factors. Like as you said, one of the is the water pollution, but not only that, even the air pollution, and then from there, the pesticide used into the farming, then adulterations, then artificial fertilization. So many things are happening, and these are causing inflammatory disorders into the people, dysregulating the immune system and causing such type of post-infectious problems and inflammatory disorders. So there are a lot of things to be done. Um like we are from infections to immunological to autoimmune disorders. So that way we are going now
Yeah.
because of so many things. So
So we're
thank you,
fighting at
Narayan.
too many fronts.
Yes, I mean after post-COVID specifically, uh, we are seeing a lot of these cases, even eczemas, urticarias, angioedemas, anaphylaxis also. The same way, this is post-infectious refractory coughs, and then now this GB syndrome like diseases that way. So thank you, Narayan sir, Sidhu ma'am, and thanks to IGC for really giving a platform to discuss an important issue. And if anything comes in future, definitely we'll follow the same topics and we'll discuss on that. Thank you. Thanks a lot. Thank you, sir.
Thank you.
Thank you.
Thank you so much, everyone, for joining and sparing your important time on this important topic. As we know that, like in our country, we give very least important to the healthcare knowledge. I hope this session will be very much impactful on everyone lives as our knowledge sharing. As we know that people try to Google it. If there is any problem, they try to search it and try to get the solution from there. But if they get the solution from expert like you, and they will be very much helpful for them also, as well doctors also. If the patients knows about the disease, it become easy for the doctor for the treatment also. I hope it will change like our ideas and make the population aware about the knowledge of this GB syndrome, and it will very much impactful. And thank you so much everyone for your valuable time. It was very interactive session, and I would like to thanks for your important time once again. Have a great day. Thank you so much.
Thank you.
Thank you, ma'am.
Thank
Thank you,
you.
sir.
Thank you so much.
Night.
Thank you, Dr. Varad. Thank you, Situ.
Thank